examine medical genetics and treatments of cancer and some other diseases. So first, let's start with this idea of there are factors that contribute to diseases, and trying to relate how much a factor relates to, correlates to, or even causes sometimes comes with a coefficient. So how closely related are these two things? How does one influence the other? So this is a value between -1 and +1. +1 being a perfect positive correlation. When A increases, B increases. -1 being a perfect negative correlation. When A increases, B decreases. Or 0 meaning there's no correlation at all. So when you are investigating two factors, you're looking for an association. Do they follow a pattern? So researchers have been trying to associate different epigenetic factors with certain diseases. And there are three ways that they can look at this. One, does the epigenetic change directly contribute to the disease symptom? So is it a cause and effect relationship? Two, does the disease symptoms cause epigenetic changes? So a reverse cause and effect relationship. Or three, is it an indirect association? Because there is an environmental agent that does two things. One, it causes the disease symptoms, and parallel, it causes epigenetic changes. But the two, the symptoms and the epigenetics, are not direct. Okay? So researchers have made associations with epigenetics and a variety of these diseases, from Alzheimer's in the brain to cardiovascular diseases to diabetes, multiple sclerosis, asthma, and cancer. And we're going to focus mostly on cancer. So there are a certain number of changes that can occur and that can be related to cancer. One, DNA methylation. So we know that usually when you methylate a gene, you turn it off. So if you hypermethylate tumor suppressor genes, you're going to cause them to be inactive. Two, you can do these covalent modifications. So remember we talked about putting modifications on the tails of histones and how that can change them. And you can increase oncogenes or decrease tumor suppressors using covalent modifications. And you can do chromatin remodeling, where we are changing the locations of our nucleosomes, which can, again, increase the expression of oncogenes or decrease the expression of our tumor suppressors, depending on how you remodel them. Okay? So here are some mutations that have been linked to cancer. So one, in DNA methylation. Here's our histone modifications and our chromatin remodeling. These enzymes or genes should be familiar from when we talked about them in epigenetics. And here are the cancers that they are related to, okay? So DNA methylation and acute myeloid leukemia, histone acetylation modifications, methylation and demethylases have been associated with colorectal, breast, pancreatic, renal, multiple myeloma, esophageal, okay? And then chromatin remodeling, lung, breast, prostate, pancreatic. So you see it's a wide range here, depending on what's going on. But we know that mutations in these three can lead to different types of cancers. The other way that they can lead to cancer is by altering the function of chromatin modifying proteins. Okay, so here we have a list of agents, environmental agents, that can modify the function of chromatin, that can alter the function of chromatin modifying proteins. And so these agents can directly alter the functions, or they can initiate several cellular changes that will ultimately affect the function. Okay, those changes can be affecting DNA methylation, histone modification, and the chromatin remodeling. Okay, and then again, like we've seen before, these agents are associated with certain types of cancers. And you should start to see like there are a set of cancers that are highly associated with epigenetics. We've seen leukemia, we've seen myeloma, breast, prostate, lung, again and again. Okay. So why is this important? Well, one reason is, we looked at our cancer treatments now, from surgery to non-specific treatments that are radiation and chemotherapy. But if we can target these epigenetic changes, we can make a more specific treatment. So we can inhibit the growth of cancer cells by targeting DNA methylation or those covalent histone modifications. And it has been shown that if they inhibit DNA methyltransferase, they can treat some forms of leukemia. Okay, so now let's turn our attention and switch gears slightly to revisit those non-coding RNAs, because they too have been associated with human diseases. So the first one was this RNase MRP. Now this is an RNA protein complex involved in processing rRNAs, mRNAs, and mitochondrial RNAs. It's a ribosome, and it's associated with the disease called cartilage hair hypoplasia. Okay, these patients, short stature, underdeveloped hair, short limbs, predisposition to cancers, and they have this defective T cell immunity. This was the first one identified, okay, because the gene encoding the RNA of that RNase MRP was associated with CHH. Since then, researchers have identified many, many more. So here are some, okay? So this is showing us the non-coding RNAs, the diseases that they are associated with. These diseases range. So there are some microRNAs called the MIR-200 family associated with cancer. So what happens is these genes that code for the RNAs tend to have a role in tumor suppression. They tend to inhibit EMT, which is epithelial mesenchymal transition. This is important in metastasis or metastasis. So they play a role in metastasis, okay? Remember too, this is a normal process, but it's tightly regulated. And so when it's not so much regulated, cancer can happen. Hot air. Remember we looked at hot air. Hot air has been associated with cancer. However, hot air is like an oncogene, and now high levels of hot air can lead to breast cancer, lung cancer, colorectal cancer. Then we have those peewees, so the ones that we know whose job it is to limit the movement of transposons in our germ cells, can lead to testicular cancer, because that's where you will find those germ cells. All right. Now, non-coding RNAs are also associated with neurological disorders. So here we see Alzheimer's disease. It's important to note about 70% of all microRNAs are expressed in the brain, and that expression is highly specific to neurons. So abnormal levels of microRNAs have been associated with neurological diseases. And we just said here, Alzheimer's is one. This familial ALS is another, okay? Then it has a link to cardiovascular diseases. We can see heart arrhythmias, damage to heart tissue, formation of plaques. So you'll see non-coding RNAs have been linked to cancer, neurological disorders, cardiovascular disorders, and even autoimmune disorders such as multiple sclerosis. So how can we use that to our advantage? We can target them, and it depends on which way they're going. So if it's an overexpression of microRNAs, we can inhibit it. So there's a therapy called anti-miRNA oligonucleotides, or AMOs. Its job is to inhibit microRNAs by having molecules that are complementary to it. And two types have been made. So locked nucleic acids, LNAs, or antagomers. And these things are created to be complementary to microRNAs. Or if it's due to a reduction, we can restore the function of microRNAs. So a couple ways to do this is by using a viral vector to restore microRNAs. Increase the level of the microRNAs processing machinery. So remember the drosha and dicer. Or put in DNA demethylating agents so that we can reverse the silencing of them put on by methyl groups. Okay. Now, those therapies are leading us where we have been going toward the future, which is this personalized medicine. So this is something that you should have been hearing about for some time now, because people keep talking about, oh, with the advances in genetics and how we'll get to that $1,000 genome, that personalized medicine is going to happen sooner than we know. So what exactly does it mean? It's looking at a person's genotype and other clinical background information to select a certain medication or therapy that's specific to their condition. So you've heard of these commercials on TV that say, oh, are you HER2 positive or HR positive, HER negative? If so, this is the drug for you. Okay? Let me back up. So we can look at the genetics of the person, and we can profile the tumors to see what type they have. So looking at the mutations that's specific to their tumors and looking at their genotypes surrounding certain things helps us to target these medications. And so far, they exist for a couple different diseases. So one being this CML, so this chronic myelogenous leukemia, then tamoxifen and breast cancer, and this Ibrance is all over the news now. So that's the HR plus HER negative metastatic breast cancer. So by profiling the tumors to see what the mutations are specific to that, and by genotyping our patient to see what their specific genetics are, allows us to make specific target medication that is more potent in combating their disease, or in this case, cancer. So the other side of this is pharmacogenetics. So now this is looking at how the genetics of a person will affect how they respond to medications. So you know how you hear about a wide range of side effects. Oh, from a headache to death, right? And one of those things could be the genetics and how your body is metabolizing that medicine. So we know that there are several factors that affect how our body responds. So one, if we take an oral drug, how long does it take it to go from our digestive tract to our bloodstream? How long does it take a drug to go into the cell that it has to be in, the target cell? How long does it take it to get in that cell and affect the function of the target protein? How long does it take for a drug to be taken up and metabolized by our liver? And then how long does it take for us to excrete it from our body? Because if you're taking a drug and you have a high rate of excretion, you might be getting rid of it before it has the time to function. So these things matter when we are picking drugs for people. So traditionally, it was almost this one-size-fits-all, watch out for side effects. Now we're trying to say, no, we can make subsets of drugs that we know work better in certain individuals. Now we are targeting this medicine in a better way. So we no longer have to throw things at the wall and see what sticks, see what's going to work in our patients. Now we can take the guesswork out of medicine and say, hey, if we can sequence these genes in the person and sequence their tumors or whatever their disease is, we can come up with a target form or target therapy. Okay.